This episode of the Berry Chronicles is proudly brought to you by Bariatric Support Australia.
Hey everyone, so we're here with Dr. Nellie from the University of Melbourne.
Yes.
Dr. Nellie, thank you for joining us on the Berry Chronicles. Tash and I have been so excited about this podcast.
It's a pleasure.
You're the first endocrinologist that we've been able to interview so far. That's really exciting for us. So could you start off by telling us a little bit about your journey and how you became an endocrinologist and really the passion for the research that you have for patients that are living with overweight and obesity?
Lovely. Thank you. Hi, Dave, and Tash, and hi to everyone who's listening. Thank you for having me. And yes, I'm very much as excited as you are to be on your podcast. So I'm an endocrinologist, meaning that I specialize in hormones and what they do in our body. I have always been very much interested in chronic disease, and also the interesting thing about endocrinology is it's one of those fields that there is very minimal things in the endocrinology field that we can't actually treat. So it's one of those medical aspects that we can make impactful and meaningful changes in people's lives, and that's why I chose this field. I've been passionate about obesity, treatment of obesity, research into it, and also consequences of obesity such as diabetes. So most of my research is around these fields, and I lead the medical weight management clinic at Austin Hospital, which is one of the leading clinics in weight management in Australia. Yes.
Thank you for all that you do.
No, it's my pleasure. It's a pleasure taking care of our patients. They are impact that we see in our patients' lives is the buzz that we need to go ahead.
I can well imagine that. It must be rewarding to see people getting the treatment that they need to be able to go on and lead the life that they're hoping for.
Certainly. And giving them the power and the knowledge to know that there's more to what they have been told all of their life, that it's their fault or they can't change anything. That is the main rewarding aspect. And my God, people are so appreciative. And what we see, the outcome in their life is the most rewarding part of it.
Yeah, because obesity is so often misunderstood, isn't it? It's just sort of put down to eating too much and sitting on the couch, and it's made out that it's our fault.
Yeah.
Yes. So that's the most important and one of those things that makes me very, very upset, which is thankfully changing. So obesity is a chronic medical condition. It is not a choice. Yes, lifestyle choices do have an impact, but it's not just a choice or anyone's fault. We don't tell someone with high blood pressure that it's their fault. It's no one's fault. It is a chronic and complex hormonal imbalance, which multiple genetic and non-genetic factors play a big part in it. And we're talking about obesity as a disease, not just having a few kilograms above your, size 10 measurements. As a disease, this is something that is impacted by our genetics and hormones.
Wow.
So what are some of the key biological genetic factors that play into the disease of obesity?
So looking at human beings as gender, so for women and men, there's two different factors, but I can say one of the most important factors is genetics. What we are handed over from our previous generations and our ancestors makes a huge impact. I'll give you an example. Our body, the human body, is designed to survive. And we're designed to survive famines and wars and not having a fridge. And we were not supposed to have a fridge. We were supposed to live in a cave and live off, hunt and our winter supplies. So we are designed to hang on to that weight as a rainy day scenario. So If our ancestors have gone through periods of famine and wars and hardship, the harder it has been for them to survive, our body is more predisposed to hanging on to that weight. I've got patients who have been, their ancestors have been the survivors of the Irish potato famine. And guess what? They would crave when they're putting on weight. So this is one of the most important factors, what you're handed over from a genetic predisposition. After that, there are multiple medical conditions. For example, in women, polycystic ovarian syndrome would be a predisposing factor. In men, other medical conditions, would be, what medications you're taking, what sort of other background medical conditions you've got. So there are multiple factors. And yes, lifestyle is a big impact. It has a big impact. But our lifestyle is also impacted by our genetics and hormonal imbalances.
Wow.
I think it's so good for those of us listening to hear this, particularly those that have had overweight and obesity, to understand that the research from people such as yourself and other people that are thankfully understanding that this is a multifaceted condition with not just one answer. That's correct, isn't it?
Exactly. That's completely correct. And a very essential factor. I have people who come to me completely depressed, completely dissatisfied with themselves, blaming themselves. I'm doing everything. I'm in the gym 5 days a week. I'm restricting my diet. I'm doing this. Nothing is moving. I look at their blood tests. They have severe fatty liver disease. Of course, their liver won't work the way that it should be working. So they won't get the results of a person who doesn't have that. So really important to look at a person as an individual, assess them, look what is applying to them, and take away the blame. The blame is a very big limiting factor in any aspect of treatment of obesity, whether it's early stages, whether it's medical, whether it's surgical, whether it's a combination. The blame game has to be taken out. And this is something that we are seeing more and more these days because we've got new therapies and everyone has an opinion. And just go onto the comments of any social media post that you can see. Half of the comments are blaming the individual. And that's out of complete ignorance.
Yep.
Totally agree with you. I completely agree.
And I love seeing, I'm on LinkedIn a lot, and I love seeing that there are more and more doctors and professionals that are standing up and saying, no, that's not right. Stop blaming the people for things that are out of their control.
Exactly. And LinkedIn is actually an interesting place because LinkedIn is a professional sort of a platform. So you expect more professional comments, and you might have seen some of them because I've seen you comment on it. Like medical professionals who put on articles that are basically scaremongering articles for people about medical treatment that is now widely available and trying to scare them off. They would not say such a thing about chemotherapy medication, or they won't say such a thing about, hypertensive medication, but they're very quick to put up a single article that looks at a sort of a relative risk of something which is not even a causation and try to scaremonger people to stay away from treatment. It's at least very irresponsible of them. So, and I see that's day to day.
Yeah. And I'm so grateful when I see people like yourself, and there's also a Dr. Julie, I think it's Manessa. She's quite active in standing up for people, and it's just really refreshing, I think, for us because we come from where doctors used to blame us for the way we were, and
we would often say, our grandmother would go to her GP, come home, and she would frequently be in tears, and she would say to us, it wouldn't matter if I went in with my head hanging by a thread, they would tell me it's because I'm overweight.
Yeah, and I see that. Yeah.
And we're just so thankful that narrative is changing, but it still needs to change further.
We've come a long way but there's a long way to go. I
Yeah.
saw a patient of mine today who has diabetes, has been dealing with obesity, has heart disease, and she's done wonderful. Her sugars are under control. She's lost 20 kilograms. Yes, ideally she needs to lose another 20, but she's done a great job. And she was so stressed today because her cardiologist had told her, you still need to lose a lot of weight. You know, that's the thing. We don't see the sort of full part of the cup, and we're just looking at the empty part. We have to look at the whole picture. We can't blame people. Look at her achievements, and we see that. And talking, having these podcasts, having conferences, trying to educate, because a lot of the medical profession, you'll see that if we talk to each other, people are open to change. It's out of ignorance and not knowing that prejudice comes along.
Yes.
Yeah.
So could you explain to us the role that hormones play in weight regulation?
Sure. So hormones play all the role. So it's all our hormones that do the job. So to give you an idea, we have one hunger hormone and we have about 12 known satiety hormones. So that is how strong our hunger hormone is. We need 12 hormones to regulate it. And we're still not regulating, and we have all these problems. The hunger hormone changes very drastically. Every time we lose weight, our body changes the hunger hormone and satiety hormones to get us up to our set point weight. Because of that survival mechanism that I mentioned, we are not supposed to lose weight. From a baby up to adulthood, we are supposed to go up with our weight. Anytime the body loses weight, the body goes into a crisis mode. It thinks that we are in a famine or we are sick, and it tries to hang on to the weight. So that's the whole mechanism, the balance between the hunger and satiety hormones. And I can tell you, there are so many hormones that we don't even know about. The GIP hormone, which is one of the most important hormones now playing a part in the next generation medications, was discovered, 20 years ago. We are just figuring out how it works. We actually still don't know how it works. So this is how complicated this issue is. It is not just a choice. Our bodies are much more complex than this to be just a choice and this random.
So we're 20 years in.
Yeah.
And still don't know how it works.
Still don't know. And if you ask me how the GIP hormone works, I will be telling you, I don't know. It does something with fat metabolism. That's as much as we know. But we know that it increases the impact of the other hormones. We used up to 50% now based on the new studies. And there are other hormones coming and other medications coming that shows how diverse this regulation is and depends on the person. For example, you mentioned, Tash, you've got PCOS. Someone with PCOS has been built in with this metabolic error. You have no chance in metabolizing carbohydrates on a normal basis. You don't. It's like you're allergic to carbs, and your body changes your regulation of your insulin based on your predisposition to carbs. So one piece of bread, for example, which could be nothing for me because I don't have PCOS, could be completely changing your metabolism depending on the degree of PCOS that you've got.
So after bariatric surgery, what has happened with me, about 18 months post-op, I started experiencing, I had dumping syndrome from the get-go as soon as I had the surgery. But from 18 months post-op, it's like it suddenly became the Hulk, and anything over 11 grams of carbs, I will literally pass out.
Yep, you got, and that's because of the insulin changes that happens. So together with the dumping syndrome, you're getting an insulin surge, and the insulin surge overcorrects your sugars. So you drop, and that's because your body doesn't know how to regulate carbs. The theory behind PCOS is, and we don't know why PCOS happens, again, not enough research. We were supposed to live in a cave, eat off hunt and berries, and then we started farming and we started eating grains, and our bodies were not supposed to metabolize grains. So what does nature do? Okay, let's do natural selection. Let's stop passing on the gene to the next generation. How do we do that? We make the female infertile by stopping them from ovulating. So when a female with PCOS is exposed to any level of carbs, and it's different person to person, you get a spike in your insulin levels, and that dysregulates your male and female hormones and changes in the balance in a way that you don't release an egg each month. And as a result, you will reduce your chances of fertility.
Wow.
It is like being allergic to carbs.
Oh.
So you either have to stay away from carbs, or I give you the hormones that you are lacking or not working the way that it should be. So that's why when we use the new generation medications in a patient with PCOS, their response is much more than the standard person without PCOS and the same weight.
That makes complete and total sense.
So is that why so often we see people that have suffered with PCOS and they start on their high protein, they've cut out all their breads and cereals, and suddenly, oh my gosh, I'm pregnant. I wasn't expecting.
They start ovulating again because they're not having that hormonal imbalance. What happens with PCOS is we've got two brain hormones that regulate the ovulation. One of them goes really, really high, so the eggs start getting big, but the other one that is in charge of releasing the egg doesn't go high, so it stays low. So these eggs come to the surface of the ovary looking like cysts. We don't have cysts in PCOS. It's a wrong name. It's an old wrong name. These are follicles. These are people's eggs. So the eggs don't get released. And that's why people don't have periods, they don't ovulate, and they don't get pregnant. But if you run out of your eggs, let's say you're 45 years and older, you don't have eggs. If we do an ultrasound, you won't see the follicles on the ovaries, but it doesn't mean that your PCOS has gone away. Your PCOS is inbuilt in your DNA. It's there, but they don't see it on the ultrasound. So very commonly I get this comment from my patients, oh, my doctor has told me my PCOS has gone away because they did an ultrasound and there's no cysts. That's wrong. PCOS is like the color of your eyes. You are always going to have it, regardless whether you are 18 or 25 or 65. It's always going to be with you.
My goodness. So obviously that is why, for me, because I'm 47 now, why I still have, like, I have a tendency towards facial hair, all of those different.
Yep, and you'll be getting menopause on top of it as well, which will just make things worse.
Yeah. Wow.
Yeah, so because I specialize in women's health as well. So that's a whole other concept. So all you've seen with obesity, times it by 10, and that will be the lack of research in women's health. So up to recently, and recently I mean a few years ago, women were looked at as a smaller version of men. So there was no specific research for women. So it's completely different. Our hormones are extremely different for men. So that's why we see different results. If I give you a medication for weight management, let's say, your response to a man the same age and the same size of you will be completely different because your hormonal changes depending on the phase of life is completely different as well. So that's why customized care is so important. Ideally, we need that sort of a time that we have genomics and person-specific assessments to be able to find out what medication suits people. We're a bit far from that. But even at this stage, there are things that we can do. Like these things that I just said about PCOS is just very slowly coming into international guidelines. It isn't there even yet. It's like where we were with something like semaglutide 5 years ago.
Okay.
Yeah.
So in the next 5-10 years.
Yeah, it seems like we're getting there. Things are moving a bit more faster. There is more focus on women's health now. There is more talk. I saw the new international guidelines putting medications such as GLP-1 analogs as the first line treatment, taking away metformin, thankfully, for the first time ever. So there's a bit of a battle. It's an uphill battle. There's not enough specialists in women's health at all, even in a city like Melbourne. But we're getting there. So it is hard, but the change is extreme.
Yeah. Wow.
Yeah.
So what are the current evidence-based treatments that are available for overweight and obesity?
Sure. So there's a few evidence-based medications. I'll start with the most effective and then I'll go down. I think that will be a better way to put it. So the most effective and the newer generation medications are very commonly known as the injectables, although overseas we do have oral versions of these medications as well. These are the GLP-1 and the GLP-1/GIP analogs. So the incretin analogs, basically. These fall under different brand names. So there's semaglutide, which is the mono analog, once a week injection, known often as Ozempic or Wegovy, which are basically similar agents, one marketed for diabetes management and one marketed for weight management that goes to higher dosages. There is the older version daily injection called Saxenda, or basically brand name liraglutide, which we did have Victoza available as well, which was the diabetes version of it, but that's not available anymore. That's the less effective version. And then we have the newer generation dual analogs, which is tirzepatide, which is available in Australia under the brand name of Mounjaro. It is also available overseas under the brand name of Zepbound, but Zepbound would not be available in Australia because the drug company has made a very good and sane decision not to use different names and just use the same agent because it is the same agent.
Yeah. Okay.
So from an efficacy point of view, Mounjaro, Wegovy, Ozempic, and then Saxenda. Weight, sort of percentage weight loss efficacy. That is one class. Overseas, semaglutide is available under the brand name of Rybelsus as a tablet. But Rybelsus is not as effective as the injections, and we don't have it, although the tablets have been generated in clinical trials that are as effective as the injections. And I'm hoping that one day we'll be sitting here and saying, we now have the tablets that makes the medication much cheaper and much more accessible for the wider population, because health inequity is a big problem in the management of obesity, and it comes down to how much money you've got, unfortunately.
Yes, it is.
The next sort of class are the appetite suppressants. So these medications just purely work on appetite suppression. So they do not work on fat regulation, fat sort of a metabolism regulation at all. These are the most common. The newest version is a tablet called Contrave, which is a combination of two agents, naltrexone and bupropion. It is an appetite suppressant. It's a pretty good medication, not as effective as the injectables, but used in the right population with the right combination, it can be useful in a sort of a group of our patients as well. And then we have the older medications, things like phentermine, available in Australia under the brand name of Duramine, which is a stimulant, and also combined with topiramate, which is a migraine medication, which increases the efficacy. While we don't use this much often anymore, again, in some patients, which are not many, but in some patients, it can be of use in a limited sort of amount of time. It has a lot of side effects and a lot of ins and outs that have to be considered before we use it in our patients. And then there is also Orlistat, which is the only TGA approved, it was the only TGA approved medication for weight management just up to September last year when Wegovy became on the TGA. And honestly, I have never prescribed Orlistat. It's just a bile regulation medication that stops you from absorbing fat. So it gives people severe diarrhea and stops them from absorbing.
Is that like Xenical or?
Yes. Xenical.
Yes.
Yeah.
I have lovely stories about that.
Yeah, I have never prescribed it because I don't see the need for it. So these are the medications that we have available. And in the future, hopefully near future, we're going to get the triple analogs, which would be a whole new game changer in treatment.
So it really is becoming possible for people to have some sort of weight management without going down the surgery route straight away.
For sure. So most of my patients do not require surgical management. So, for smaller amounts of weight or people I've had people lose up to 50 kilograms with these medications, but in general, the average is about between 15 to 25% body weight loss. So it depends on how much people need to lose weight and how tolerant of medication they are, and of course how much they can afford. These medications are not cheap. The average cost is between $300 to $700 a month cost. So, when you're looking at a long-term medical condition and very minimal private health subsidy over it, there's no PBS subsidy, we have to look at the whole picture in people as well.
Yeah. And that's a big thing, I think, for a lot of us. Like my endocrinologist, last time I saw him, he gave me a script for the Mounjaro, but at the moment it's just too expensive to be able to do it.
Yeah, and unfortunately, I actually spoke with the drug rep today, and she informed me that they had an application to PBS, a repeat application for a subsidy. They applied for Aboriginal Islander patients with a BMI above 40 with 2 medical conditions associated with obesity, and it got knocked back for such a small population.
Wow.
Yeah.
That is terrible.
It's horrible, and we don't see the medication becoming available on the PBS anytime soon. And we do some stuff to try to make it cheaper, but as I tell my patients, you're looking at $250 to $700 a month cost.
Yeah. Wow.
Yeah, wow.
So, I mean, I guess when we're looking at the barriers and stigma associated, there it is in a real world.
Real world.
Yeah, exactly. And often you see the people who need it most are the people who can't afford it at all. These are people, like I have patients who can't even have bariatric surgery because of their starting weight, and they're not safe to have surgery. So we need to get their weight below a certain amount to be able to have surgery. But then on the other hand, they can't afford the medication. And these are usually our public hospital patients. If someone is waiting to see us in the public setting for 5 years to get in to see a doctor to be assessed, of course they can't afford $700 a month. So then that makes us think out of the box and try to find our own funding to fund our patients, at least the small population of patients that we see in the hospital setting, to be able to get them to their target, whether it's to get a kidney transplant or whether to get their bariatric surgery, or, I have people waiting on the list to have a hip replacement. So all of these are stages that we need to try to play around with our funding and resources, which is very limited, to at least support our patients that need it.
You all do an amazing job. It's such a complex space. Yeah. And it must be truly heartbreaking at times to know that the finance is such a barrier.
Unfortunately for our clinic at the hospital, we have had to put in a criteria on our referral to explain to the referring physicians that please discuss the costs with your patients before you refer them to this clinic, because then they will be waiting on a 2 to 5 year wait list to get into the clinic to just hear that they can't afford the medication. So that's the reality of the situation at the moment. And, this brings up a big topic of, should private health insurances be chipping in more? Should Medicare be chipping in more? What can we do? Should the drug companies be helping? There's a lot of questions here, and who needs the medication more is a big question as well. If someone isn't down to chronic renal failure yet, so it doesn't mean that they need it, or should we wait for someone to get to that severe stage and then say that they need it? It's such a big medical ethics problem. But
Yeah.
I mean, even just today in our support group, a question was posed a couple of days ago about one of the GLP-1 medications, and there was even just within our community, there was just such opinions on it. I can just well imagine that it would be the same on a political level. And everything that no doubt you would deal with very regularly. But what breaks my heart is that I know that it's the people that suffer
Yeah, and sometimes comments. I was seeing, I was just scrolling through Instagram, and there was a photo of a very well-known Hollywood actor. I won't mention his name, but it seemed like he had lost a lot of weight, or he had just aged, or whatever. And it might have been for a role. I don't know. He might be sick. And the comments. Out of every 5 comments, 4 comments were, "Oh, he's on Ozempic. This is his Ozempic face. That's the evil drug doing this to him." Like, he wasn't even overweight to be on Ozempic. So most likely there's another reason. But the stigma, this just makes it normal for people to first of all insult, make fun, and no one talks about any other medical treatment for any other medical disease like this.
Like this.
Yeah,
No,
it's
it's
ridiculous.
exactly right. It's exactly right.
Yeah. I mean, no one's going to tell, like my mother-in-law, she had a hip replacement. I'm not going to tell her, "Oh, you cheated. You should have done a bit better exercise." And, like, you don't do that to people.
Exactly. And it's not like that. Our body is designed to actually compensate for things. So let's say you have high blood pressure, and I tell you, well, if you limit your fluid intake and go salt-free with all of your diet, your blood pressure will come down. It actually wouldn't happen like that. The body will start to retain the fluid and the salt that you're not having, and it will go into a reciprocal pathway. So it's complete ignorance of people to say something like that. From a certain weight, above a certain BMI, and I'm using BMI because we don't have anything better at this stage, but it has its own limitations. But from a certain level upwards, the metabolism goes into a complete reverse cycle. You can limit your calories to 800 calories a day, and nothing would not happen. Nothing would happen.
Yep.
Because your body is sticking onto it. It's not letting you lose the weight. And we need a reset of the metabolism. And when you talk about this, people just look at you blankly like you're talking, in a space language or something. That is proven by science. We know this. It's completely shown. And yet we still hear, go and run once a day and limit your carbs. Yes, these are all fantastic measures, but we know that at best, all diets, and all diets have been studied, cause 2 to 5% body weight loss at its max. So if you need to lose 35% of your body, diet and exercise is not going to do that for you.
I remember many years ago, after because I had a failed lap band surgery, and obviously I understand and know that I did not fail. It was just
it's just a horrible procedure. Yeah, it's just not a good
surgery. Didn't work for me. It wasn't great. But I went to my GP, and I remember him saying to me, because of my weight, I had less than 1% chance of being successful in maintaining any kind of weight loss beyond about 5 to 10% over a period of 10 years. And I looked at him and I said, "I will prove you wrong." And eventually I moved states, but I went back to him when I visited my home state of Queensland, and I apologised. And I said, "You know what, you were completely right." I mean, he probably didn't remember me, but I remember the attitude that I had about that. And what I know now that he was trying to get through to me is that this is genetic, and this needs a fix beyond your ability to stop eating carbs.
Exactly. And that's completely true, especially with the PCOS in the background. And and that's a fantastic GP and very ahead of their time. Very ahead of their time.
100%.
Yeah, because you don't get that often. Yeah.
I often think, wow, like, yeah,
that's a fantastic GP, and that's really important for people to know. A lot of it is now out of your hands. And yes, if we intervene early, if we are getting children as young as 8 years old getting type 2 diabetes, this is a big public health problem. It's bigger than any other problem that you can see, but closing the policymakers' eyes, closing their eyes has been very easy for them, rather than putting in policies. Why should an 8-year-old have type 2 diabetes? Well, the only reason is they are dealing with obesity. And why is this happening? Because our genetics are changing, the food around us is changing, our body metabolism is changing. If we intervene early, we will stop people getting to those BMIs of 40, 45, and 50, which will just change the metabolism in a way that makes things harder. So early intervention is important. I know that the policymakers and the TGA criteria, for example, says that the indication of starting medication is a BMI above 27 with true medical conditions. Well, I can say I'm guilty of prescribing for lower BMIs if I see a need for it. If someone has prediabetes, if they already have fatty liver disease, if they have central adiposity, I'm not waiting for the BMI of 26.5 to get to a BMI of 27 for them to start medication. We have to intervene early to stop the progression. It's a progressive disease.
That's right.
Yeah.
It's not just you're eating too much. It is a disease.
Yeah.
It's like any other disease. If it was a cancer,
Yeah.
we would be applauding
Yes.
everyone for jumping in early and getting it early.
Yeah, exactly.
What are the,
Yeah.
sorry, what are the like minimum age that someone could go on something like Mounjaro or
The TGA approval at the moment is 12.
Okay.
Yeah.
okay.
And it's because
Well,
of the limitation of research. And I think that's fair. 12 is
Yeah,
pretty
yeah.
I don't prescribe for children. I'm an adult physician, but the TGA approval is 12.
Wow.
Yeah.
Okay.
Because it like we actually touched on. I recorded a few actually when there was talk of nurses at schools, sort of doing the whole weight thing, and we were horrified because we went through that at our school. We were humiliated in front of classmates and
Made to get weighed
and all that. I think early intervention is great if it's the right intervention.
Exactly. So those measurements that you just mentioned, those will result in eating disorders. It's very clear. Doing that sort of a level of, for a child, that would just cause lifelong eating disorder. What should be done is education of the parents, not the child themselves. Most important thing, and as I said, I'm not a pediatrician and I just deal with adults, but the most important intervention in children initially is physical activity. That works in children. And then, dietary choices and all of those things at a young age, and then monitoring, and then if needed, early referral, not shaming, not blaming. Again, you cannot shame and blame a child. Oh, you cannot shame and blame anyone, but in a child perspective, it's completely different. So yes, so those things will just result in eating disorders.
Agree.
Yeah.
Totally agree.
Amazing.
Yeah.
Amazing. So when we have for people that are struggling with their weight and might be listening to this, and where do they start with looking at getting help?
So the starting point is your GP. But I do understand that access to GPs, a regular GP, is not available to everyone. So some people might not even have a regular GP, or you might not be as lucky to have a GP who's up to date in the field. So approach your GP. If you don't get the sort of answer that you need, if you don't get a plan, and a plan is a stepwise plan, it might not immediately start with medication or surgery or something like that, but it has a trajectory. So what would we be doing in 3 months, or what will happen in 6 months? You have to set goals, achievable goals, what our plan are, and go from there. But if you see that your GP is not giving you what you need, or you need more input, go to another GP. Look for and there are multiple weight management clinics at the moment set up by fantastic general practitioners that take a big load of our community need for treatment. Not everyone needs to see an endocrinologist. We don't have the capacity, basically. There's not enough of us. And, we are in a community that we have a 70% population rate of overweight and obesity. So you can imagine how many people that would be. So start with your regular GP. If your regular GP is not comfortable in the field, go and look up, weight management clinics that are available everywhere. There are multiple telehealth services. I suggest that these are services that you actually see a doctor, whether it's face-to-face or telehealth, not the online apps or something that would be giving you a generic prescription. And if your GP or the weight management people tell you, no, your case is a bit more complicated for me, you need an endocrinologist, certainly. There are a good amount of endocrinologists who specialize in weight management. Not every endocrinologist sees weight patients, and that's fine. Everyone has their own interest areas, but there are a lot of us around who could be helping. But don't think that you're left alone. There's even now gastroenterologists and cardiologists initiating medication because of the fantastic benefits from a cardiac and liver perspective. So
Wow.
the aspects are growing. Yeah, like I've got cardiologists who call me on a daily basis, like, we're going to start this. Respiratory physicians. These medications are FDA approved for the management of sleep apnea. You can't imagine how many patients I've got stopping their CPAP machine because of the medication.
Well,
So it's a growing field. So there's so much support out there.
That's really exciting to know. It really, really is.
And the most exciting thing is we don't have medication shortages anymore. We have abundance of medication. We went through 2 years of hell. No medications, trying to source proper sort of a good compounding medications. Then the compounding got banned, but now we actually have the front runner best medications on the planet available in this country, and they are available, and we don't see a shortage happening unless something out of usual happens, like COVID. Hopefully not. So there are choices and there are options.
That is so exciting. Now, just on the front of people being able to find endocrinologists that do specialize in this area, because I was privileged in that I was able to access an endocrinologist that did work with a bariatric surgeon, or at least had liaised with my bariatric surgeon on a number of different patients. I feel like I was very privileged in my personal situation, but it's not always easy to find you guys.
Yeah.
Find you, like,
Yes.
how to find people that
There's no
specialize.
directory per se to be able, you can search people by Google search and using keywords, and all of us, we all now technically legally need to have a website. So if the word weight management is indicated on someone's website, they will be seeing weight patients. So that will be the easiest way.
That is a fantastic tip.
Yeah.
Because I'm asked quite often, well, how do I find one? And I really was unsure. I didn't know if you had an overarching body.
Not at the moment, but there is the Endocrine Society, the ESA, Endocrine Society of Australia, which does have a series of endocrinologists listed. But for example, I'm not listed there because, I haven't been part of that society. But, that is something that you can have a look at. The other thing is that I usually use for my patients, and this is for any doctor that you need. There's a website called HealthShare, and HealthShare is fantastic. You go on HealthShare and you just search, for example, endocrinologist and then your suburb, and it will bring out every single endocrinologist that is around your suburb with their interest areas, with their referral details, everything. We are all on HealthShare because it's needed for e-referrals and everything. So there is no doctor who's not on HealthShare. So any doctor you need, you go on HealthShare. It will tell you whether they are with the private funds, whether they do inpatient, outpatient, whether they offer telehealth. Everything is there.
Perfect. Thank you so much for that.
Yeah.
So it's very helpful.
Dropping that one in the description as well, so that everyone can access.
Yeah. So one more question.
Sure.
If you could share one key message about treating overweight and obesity, what would it be?
For patients or for just generally?
You can pick.
General. I would
General.
say weight problems are not a choice. Stop blaming the individual. It is a chronic medical condition and needs treatment like any other chronic medical condition. The treatment can be different based on the person. Treatment has different phases, but people need chronic treatment for this. And if we get that if that's engraved in stone and believe that it's a chronic medical condition, a lot of things will change.
Amazing.
Well, we believe it, and we will keep talking about it and talking about it.
And that's great. What you're doing is fantastic. Reaching out to people, hearing, the lived experience is really, really important. It's like anything else. We tend to not know how things feel until we experience it ourselves. And when we hear someone exactly like ourselves talking about it, someone that we can actually put a face to and put an experience, it's very different from looking at the case sort of scenarios that you're presented in medical school. A 60-year-old gentleman presents with a BMI of la 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 la. That's not real. That's not true. When you put a face to a story, that makes a difference.
Amazing.
Thank you so much, Dr. Nellie.
My total pleasure. Thank you for having me. It's very exciting, and I think we're living in a very good time, and there's a lot of good things happening.
Yeah.
We'll look forward to chatting again.
For sure. Look forward to chatting to you guys both again as well.
All right.